All right. So, ladies and gentlemen, good afternoon, and welcome to our webinar on prostate health. So, my name is Javan Gray, registered nurse and vice president of the Omega Kappa chapter of Sigma. And I'm honored to be your host for this important and timely event. We are delighted to have you join us today as we delve into a topic that impacts so many lives, but it's often not discussed openly enough. Prostate health is a critical aspect of men's overall well-being, yet it can be shrouded as misconceptions and lack of awareness. Our goal today is to shed light on the importance of prostate health, provide valuable insights, and answer questions you might have. Whether you are here to learn more for yourself, a loved one, or simply to expand your knowledge, we are here to provide you with the information and the support you need. We are privileged to have with us two male nurse, two male nurse leaders who will bring a wealth of experience and knowledge in the field of urology and prostate health. They will share their expertise, latest research findings, and practical advice to help you better understand the complexities of prostate and how to maintain its health. This webinar will be recorded and is also live streamed over by Zoom, so you can share our link. We also ask that you participate actively by posting your question in the chat, and close to the end of our session, we will answer these questions. Please, I'm going to ask all persons who are on Zoom to mute your mic. Today's discussion will cover a range of topics from the basic prostate anatomy and common prostate conditions to the latest advancement in treatment options and preventative measures. Our aim is to empower you with knowledge and practical tips that can help you to control your prostate health. So without further ado, it is my pleasure to introduce to you our first speaker, who is no other than Mr. Shesman Finley. Nurse Finley is a proud graduate of the Navarro College of the Corsicana, Texas, where he received an associate degree in science with honors. After completing his studies at the Navarro College, Nurse Finley then enrolled in the College of the Bahamas, where he received a Bachelor of Science in Nursing degree with honors. Nurse Finley worked as a registered nurse for 8 years in a variety of different areas, including ambulatory clinics, the National HIV/AIDS Program, and the National Disease Surveillance Unit. Today, Nurse Finley leads the Male Health Initiative of the Ministry of Health and Wellness in Bahamas, which he seeks to promote health and wellness among boys and men. But what Nurse Finley is most passionate about is his family and serving the Lord. So please help me, welcome Nurse Finley.
Hi, good afternoon, everyone. I'm going to start sharing my screen with you. Okay, so again, my name is Nurse Finley from the Bahamas Ministry of Health and Wellness Male Health Initiative, and I just want to say thank you for the invite and being here for this opportunity to share with you. So, we're going to be talking about prostate cancer. We're going to quickly go over the anatomy and the function of the prostate gland, introduction to prostate cancer and its symptoms, some diagnostic parameters, statistics, and then our point of emphasis will be prevention versus risk reduction. And we'll briefly go over some treatment options and then some tips. So, the prostate gland is the walnut-sized gland that is located in front of the rectum and just underneath the bladder. It surrounds the urethra and carries semen and urine. Sorry, that carries semen and urine through the penis. So in this diagram here, we can see that right underneath the bladder lies the prostate gland, and we see to the back of it lies the rectum. So every man has a prostate gland, and we know that as a man ages, his prostate gland enlarges, and that's just normal. So what is prostate cancer? So prostate cancer is the malignant growth of cells in the prostate gland. This malignant growth can either be localized, regional, or distant. Localized meaning that the prostate cancer or the tumor is only in the prostate gland. Regional means that the tumor has begun to spread to surrounding tissues, and then distant means that it has begun to spread to other organs like the bone or liver. So let's look at our symptomatology. And the first thing we have is asymptomatic that is highlighted in bold. And that's because, like hypertension, prostate cancer too can be a silent killer. We know that in localized prostate cancer, a lot of times the patient remains asymptomatic. So it's very important that when we discuss prostate cancer, we allow persons to know that you can have no symptoms and still have prostate cancer. Additionally, there can be blood in the urine. There can be some level of renal insufficiency. There can be nocturia, where there's an increase in frequency in urinating at night, painful urinating, some levels of erectile dysfunction, blood in the semen, pelvic pain, back pain, lymphedema, weak or interrupted urine flow, and unintentional weight loss. Let's talk about our diagnostic parameters because this is where it really becomes interesting. So we know that with prostate cancer, the first line of screening, besides your full history, is going to be a prostate-specific antigen blood test or your PSA. So the PSA is the gold standard. It is the gold standard because it's affordability, accessibility. So we know with the PSA that the goal of this test is that it's looking for an antigen or a protein that the prostate gland produces. And in prostate cancer, this antigen or protein is going to be produced at an increased rate. So the normal range for the prostate specific antigen blood test is less than 4 nanograms per milliliter. Now, now that we know that it's 4 grams per milliliter, there's also going to be a sub categorization of these values. So if you're a male, yeah, you're going to be a male. Sorry about that. So if you're 50 years or younger, the PSA score should be less than 2.5. Anything that's going to be above 2.5 is going to be considered abnormal. Now, here's the catch to this. Not because it's above 2.5 means that it's prostate cancer. It just lets the clinician know now that there is some further investigation that needs to be done. Because we know that there are some things that can cause an elevation in the PSA. One of those things can be BPH, which is a benign growth of the prostate gland. It's non-cancerous. We know that strenuous exercise or strenuous activity can cause an elevation in the PSA. We also know that sexual activity can also cause an elevation in the PSA. And research has even found that um, extended periods of riding a bicycle can cause an elevation in the PSA. So, not because the PSA is elevated above the safe parameter means that it's prostate cancer in every instance. Okay. So, for men aged 60 years and older, any PSA score greater than 4 will be considered abnormal. So I just thought I would make that clarification that not because it is abnormal means that it's going to be prostate cancer. The second thing is the digital rectal exam. Now we know that the National Institute of Care and Excellence Guidelines, or NICE, has clearly stated that the DRE is no longer recommended. And part of that is because if we were to go back to our anatomy of the prostate, When the DRE is done, the physician inserts his finger in the rectum and is unfortunately only able to feel this portion or one side of the prostate. And this is the side where 70% of all prostate cancer tumors are going to be. The problem is when the DRE is done, physicians on average are only able to detect about 28.6% of all of the prostate tumors. So that's highly problematic. Additionally, we also know that a negative DRE does not mean that the patient does not have prostate cancer because how the DRE is performed, a physician is not able to fully palpate or assess the, the prostate gland in its entirety. So the physician is limited in what he or she can feel. So that's the challenge with the DRE. Okay. So because the DRE is no longer recommended, some physicians, some urologists do not perform it. Some still do perform it. I know here in the Bahamas, a majority of our physicians still perform it because they still find value to it. And the next step in the diagnostic parameter is going to be the prostate MRI. Now, if the PSA is elevated, the next step is going to be the MRI. If the PSA is not elevated, but your urologist or clinician still suspects prostate cancer, the prostate MRI will be ordered. Now, depending on the region you're in and the availability and cost of a prostate MRI, some clinicians may temporarily substitute it with an ultrasound of the prostate, and that will allow them to get an idea of the size of the prostate gland itself and determine their next steps. But according to the guidelines, the PSA should be done first, followed by the prostate MRI. Once the MRI is done, sometimes an MRI guided biopsy is needed. And that's simply because the MRI scans can miss some prostate tumors. I saw one article talking about how some 11 out of 28 prostate cancer tumors were missed by the prostate MRI. So when it comes to diagnosing prostate cancer, there's a number of steps that a clinician has to go through in order to get a definitive answer. So it's not like we can just do the PSA and say definitively someone has or does not have prostate cancer. So let's look at our statistics, and we're going to talk about cancer from a general perspective. WHO said in 2022 that there were 20 million new cancer cases and roughly 9 million cancer related deaths. About 1 in 5 people will develop cancer in their lifetime, and approximately 1 in 9 men will die from the disease. When we look at global prostate cancer incidences in 2020, we see that there was 1.4 million cases of prostate cancer. But then when we start to look deeper in terms of per capita, we see that Guadeloupe and Martinique are number 1 and number 2 in the world in terms of cancer diagnosis per capita. And these are our Caribbean and West Indian countries. We see Ireland third, Barbados and St. Lucia fourth and fifth, and the Bahamas 10th. So we see out of the top 10 countries, the Caribbean and West Indies ranks 1, 2, 4, 5, and 10. And these are staggering numbers. When we look at the mortality, the prostate cancer mortality, prostate cancer kills 375,000 men per year. When we look at it per capita per country, we see that Zimbabwe ranks number 1. But again, the Caribbean and West Indies come in ranking at number 2, number 3, number 5, 6, 7, and 8, which tells us that there is something going on, that there is a link between the Caribbean and West Indian men, and prostate cancer. Further statistics show that prostate cancer mortality rates are 2 to 9 times higher in the Caribbean than in the United States. So we're dying more in the Caribbean from prostate cancer than in the United States. Prostate cancer deaths accounted for 18 to 47% of all cancer deaths. And the number of annual prostate cancer deaths worldwide is predicted to rise by over 85% over the next 20 years, from 375,000 deaths in 2020 to almost 700,000 deaths by 2040. So the research is saying by 2040, they're predicting nearly 700,000 men to die by prostate cancer. We know that 1 in 6 Black men will develop prostate cancer. In the Bahamas, the Cancer Society has found that more than 80% of men that are diagnosed with prostate cancer are diagnosed with advanced disease. PAHO has labeled prostate cancer as a significant public health challenge given these alarming statistics. Also, while considering that prostate cancer can be prevented through lifestyle modifications and cured through early detection and treatment. Now, we're going to focus more on prevention or risk reduction. So, PAHO and WHO, when they talk about prostate cancer, they talk about it in terms of preventing prostate cancer. However, Harvard University and Johns Hopkins University state that because of three very specific non modifiable risk factors, prostate cancer cannot be prevented. The first and most common risk factor, non modifiable risk factor, is age. So, prostate cancer is not common in men younger than 40 years, but as a man ages over the age of 50 years, the risk for developing prostate cancer begins to increase. Additionally, race and ethnicity. Prostate cancer develops more in men of African American and Afro Caribbean ancestry than in any other men of other races. So when we consider that age is non-modifiable, your race and ethnicity is non-modifiable, and now your family history. If there's a predisposition to the BRCA1 or BRCA2 gene mutation that tends to increase a man's risk for developing prostate cancer, if there is a family history of prostate cancer, that also increases the risk. So for these very specific reasons, John Hopkins, Harvard University, they all conclude that prostate cancer is not preventable, but our focus should be on risk reduction. So, how can we reduce our risk for prostate cancer? The first thing and the most important modifiable risk factor for prostate cancer is our diet. Research suggests that the diet in the Western world may be a contributing factor to men developing prostate cancer. Some studies have already shown that men who eat a high fat diet have a higher chance of developing prostate cancer. There are studies have found links between saturated fats and a higher chance of developing advanced prostate cancer and even death. So that's the bad, but what is the good? But before we get to the good, there's also a correlation with dairy consumption and prostate cancer development. So one study found that men who consume 1 3/4 cup of milk per day, face a 25% increased risk for developing prostate cancer when compared to men who do not consume milk. And I think that's really important because as men, especially older men, we were taught as kids that we should drink our milk so that we can grow up to be healthy and strong. But now, today, research is showing that there is a strong link or correlation between the consumption of dairy and the development of prostate cancer. So, how do we reduce this risk? Through our diet. One of the first ways is to ensure that we're getting a high intake of fruits and vegetables. Lycopenes, through research, have been shown to inhibit the growth of prostate cancer cells. These lycopenes can be found in tomatoes, they can be found in your yellow, red, and orange bell peppers, they can be found in carrots, grapefruits. So, the more fruits and vegetables you get in your diet, the more you help your body be in a position to fight the growth of cancer cells. And conversely, research found that men who do not have sufficient vegetables in their diet, they have a higher risk of developing an aggressive form of prostate cancer. So the research is saying to us today, eat your fruits and vegetables so that you can reduce your risk. But if you do not eat the fruits and vegetables, your risk of developing an aggressive form of prostate cancer conversely now increases. All right. So I think that's really important. The second modifiable risk factor is obesity. Now, obesity does not increase your risk for developing prostate cancer. However, if a man is obese and he develops prostate cancer, he is more likely to have an aggressive disease. And this kind of brings to memory COVID-19. Obesity in COVID-19 didn't make you more prone to contracting COVID-19. But if you were obese during COVID-19, you were more likely to have a more severe respiratory symptoms. And it's the same thing with prostate cancer. If you're overweight, you're more likely to have an aggressive form of prostate cancer. So, one of the things we want to encourage is physical activity. And we don't want to limit physical activity just to walking or running on a treadmill. But there's swimming, there's Zumba dancing, there's so much other things that we can do to get active. I see martial arts club, I see kayaking. We're in the Caribbean, so I think we should take advantage of our beaches. So we can do kayaking, we can do biking, jump rope, anything that you can do to get more active and help reduce your BMI and stay in shape. Third modifiable risk factor is your alcohol intake. Research show that if you have a high alcohol intake, it's associated with increased risk for prostate cancer. And alcohol consumption, according to PubMed, also helps to cause your prostate cancer to become more lethal, and it shortens the time of progression from um, a localized tumor to metastatic prostate cancer. And this is challenging because we know men are more likely to consume alcohol. We know men are more likely to drink heavy when compared to women. So we're living these riskier lives in general. And then these riskier lifestyle habits that we have puts us at an increased risk now for having shorter progression times from localized to metastatic prostate cancer. And that's really challenging. Smoking, we're not sure, research isn't clear on whether smoking increases your risk. But again, like alcohol, it is linked to an aggressive form of prostate cancer. And when we say aggressive, it means it moves quickly. It doesn't respond to treatment like we would hope for it to respond to treatment. And chemicals. Men exposed to high levels of pesticide or men who would have participated in US military wars, I think specifically the Vietnam War, have an increased risk for prostate cancer. Even men who would have been around 9/11, they would have an increased risk for cancer. So these are things that we have to be mindful of. Working in environments where there's high exposure to chemicals, men who work in the asphalt industry, they're exposed to high levels of chemicals. So it's important that they wear the proper safety equipment while at work. So treatment options, we know that we can do active surveillance. Surveillance just refers to the fact that you would have been diagnosed. and the tumor is localized. Because the tumor is localized, it may not be spreading, it may be moving slow. So you and your physician may come to have a discussion and come to the agreement that it's best that you can actually wait before beginning any treatment. What will happen is you would just have repeated PSAs to monitor the progression of the prostate cancer. You'll also have repeated MRIs. Now, a lot of people do not opt for surveillance. Unfortunately, the majority of people who opt for surveillance are individuals who are diagnosed at an older age, and they are usually diagnosed in advanced disease where it's already metastatic and the prognosis is poor. Chemotherapy can also be done, but chemotherapy is only primarily done in metastatic disease, and that is done to help try and slow the spread and the progression of the prostate cancer as it spreads outside of the prostate gland. Radiation is also an option. Um, Again, these are all things that the urologist, the oncologist, and the patient and his family will sit down, discuss, and come to an agreement as what is the best course of action. But we know when it comes to curing prostate cancer, that surgery is always the gold standard. Surgery is always the number one option. Um, the surgery of choice is the complete removal of the prostate gland, whether that is done through an open prostatectomy or through a laparoscopic prostatectomy. The prostate gland is removed. Sometimes some of the surrounding tissues is also removed. So when we talk about the prostate cancer surgery to cure prostate, some of the concerns that patients typically have is related to sexual performance or erectile dysfunction. How would they look? How would they feel? What can they expect? So we tell our patients that when it comes to prostate cancer, your life is priority. Life is priority. So what they can expect is that there can be loss of um, erection that can be lost from anywhere from 2 months to up to 2 years. But there is medications that we can use. There are some therapies that we can use to help restore that. We also know that there can be some urinary incontinence, and but there's medication we can use to help with that. There's bladder training that we can help with that. We also know that there can be something called a dry orgasm. So as a man climaxes, the orgasm still remains pleasurable, but there is no semen, there is no ejaculate. And that's simply because during the surgery, if the prostate tumor has spread to the seminal vesicles, those are removed. And once they're removed, there is no way for the ejaculate to come. So that's some of the complications or the concerns that patients may have. But we always try to tell our men that it's life over limb, in that kind of concept. Once we can save your life and get you on a path to health and wellness, then we can worry about the other things and address those other concerns as they come up. But your life is more valuable than anything. So, some general prostate cancer tips. The first thing we tell our men is you have to schedule a visit with your primary care physician. The first symptom of prostate cancer is often no symptom. I don't know how many of us remember the retired NFL player, Shannon Sharp. He looks like the epitome of physical fitness. I think he's in his 50s. He still has washboard abs, in shape. And one year he went to his doctor just for his routine follow up, and he was diagnosed with prostate cancer, and he was completely asymptomatic. So it's very important that we have our annual done. We need to be open and honest with our healthcare providers. Remember that our routine labs are inclusive of our PSA. The DRE is no longer recommended, but some physicians still perform it. And I just want to say this about the DRE. As healthcare providers, I think one of the things that we should be mindful of is that we should not throw the DRE away. It is still beneficial. Every orifice needs an assessment, an exam. The DRE can not only check for prostate cancer, but it can be used as a screening measure for colon cancer, for hemorrhoids, for polyps. So I think it's still beneficial. I know there's a lot of hesitation with men regarding it, but I think too, if we can talk to our men about the DRE, the benefits of the DRE, I think then they will be more open to having the DRE done. I know last year, September, we had a massive prostate cancer screening across New Providence. And we would have on a given night, I would say about 130, 140 men lined up to the clinics, saying, although they know they're getting their PSA blood test, they want their DRE. They want their DRE done. So um, I think we should just be mindful about it. If if we are fortunate and able to practice in our profession long enough, we may see the pendulum swing back where um, the researchers come back 10, 15 years later and say, hey, the DRE is now recommended. So I don't think it's something we should just disregard, but I think it's something we should keep an open mind to, that some physicians still perform it. And pay attention to your body. The symptoms of prostate cancer: blood in the urine, blood in the semen, erectile dysfunction, unintentional weight loss. If you're feeling any way that is not normal, let your physician know, let your healthcare provider know. It doesn't hurt you or it doesn't cost you to be open and honest with your healthcare provider. At the end of the day, the more information that we can get from our patients, the better position we put them in to keep them on a path to health and wellness. And as healthcare providers, we need to be sure that when men come into our healthcare facilities, we have a confidential but warm and friendly and open environment for them. The more we develop relationships with our patients, the more they will be willing to talk to us and express what is going on with them. So let's talk about prostate cancer survival. It's confined to the tomb survival um, at 5 years. If it's starting to come out of the prostate but still in the
Finley, you're breaking up. I can't hear you. Sorry. Go again.
up, you said?
Yeah, we can hear you. I can hear you now. You can start over from that again.
Okay, so let's talk about the prostate cancer survival rates. So, if the prostate cancer is as well, and it also means that 99% survival rate. If it's regional, meaning that it's still in the prostate but starting to come out of the gland a bit, the survival rate at 5 years is still greater than 99%. Spread to the bone. Is actually great.
Finley, we're still having some breakup. It's still breaking up.
Okay.
Not sure why. So we really didn't hear much about the survival rate. It started to break up when you started again. No, I can't hear you. Your mouth's moving, but I can't hear. It's the audio. Something's going on with the audio. Hold on. It seems like your mic is muted. Give me a minute. Gotta find you. Okay. Go
Okay.
again.
Is that
Go. You can talk.
okay? I hope that is better.
So you can start from the survival rates.
Okay, so the prostate cancer survival rates. If the prostate cancer is localized, meaning that the prostate cancer tumor is only in the prostate, it is most likely not felt on a DRE. Your PSA is most likely still within normal parameters. The survival rate at 5 years from diagnosis is greater than 99%. If it is regional, that means that the tumor is still in the prostate, but it may be more felt on the DRE now. It may have come out of the prostate gland slightly. However, the survival rate at 5 years is still greater than 99%. If it is distant, that means that the prostate cancer is now metastatic and it's spreading to surrounding tissues, to the lungs, to the bones. Then the survival rate at 5 years decreases to 34%. But the emphasis is on the local and the regional, meaning that if we are having routine PSA screenings, yearly PSA screenings, we're having routine follow-ups with our physician, our primary care physicians. That means even with a prostate cancer diagnosis, that our chances of survival at 5 years after diagnosis is greater than 99%. And I think that's really important to know that once we do what we're supposed to do from our end as men in terms of eating right, exercising, decreasing smoking or stop smoking, reducing our alcohol intake. If we're doing all of these things coupled with seeing the doctor regularly, even if we're diagnosed with prostate cancer, the survival rate at 5 years should be greater than 99%. And that's the point I want us to really take home, that you can be diagnosed but have a 99% survival rate once you are diagnosed in the localized or regional stage. 10 years after diagnosis, the survival rate is at 98%. So 10 years after diagnosis, the average prostate cancer patient is just 2% less likely to survive than a man without prostate cancer. 15 years after diagnosis, the average prostate cancer patient is 5% less likely to survive than a man without prostate cancer. So 15 years after your diagnosis, your survival rate is at 95%. And I think that's pretty awesome. I think that speaks to our treatment modalities. And I think this is why it's really important for men to have these routine follow-ups. And I think it also speaks to the importance for clinicians and those that work in public health to do more to take healthcare delivery services to men instead of always waiting on men or patients to come to us. One of the things that we try to do in the Bahamas is that with our cancer society, they take PSA screenings directly to men. So they'll go to a basketball court. They will go outside of a barber shop. They will go into areas where men are congregating, socializing, hanging out, and they will offer PSA screenings to anyone who is interested. Once you are within the confines of the age bracket, they will offer free PSA screenings. So in summary, Our diet is the most important modifiable risk factor to helping reduce prostate cancer, reduce our dairy and high food intake, increase our intake of colorful fruits and vegetables. Let's exercise, let's become active. Becoming active not only helps to reduce our risk for prostate cancer, but many other chronic diseases like hypertension and diabetes. I don't know about some of the other countries that are on this Zoom, but the Bahamas, basically in our STEP surveys from 2019, the average Bahamian consumes 62 pounds of sugar per year. We are one of the most obese countries in the region. So becoming active is really important. It's going to help reduce your risk for many chronic diseases, promote heart health. It helps you to feel better, helps you to look better, helps you to live a longer, more healthier life. Want to limit your alcohol consumption, want to stop smoking, reduce or eliminate your exposure to harmful chemicals, and of course, schedule an appointment to see your doctor. The longer we delay in seeing the doctor, the more disadvantageous of a position we put ourselves in as men. So the sooner you see your doctor, you put yourself in a better position for a path of health and wellness. And that concludes the end of this presentation, this half of the presentation. I think I should turn back over now to Nurse Brown.
Great.
Oh, Mr. Gray.
Mr. Gray, sorry.
That's fine. All right, thank you very much, Nurse Finley. All right, so at the end of our session, we have our questions and answer. So I have another speaker, who is Mr. Rodrigo Ward. Is an adult gerontology nurse practitioner that specializes in urology and internal medicine. He also has extensive experience in men's health issue, oncology, and urgent care ER. In addition to being a clinician, Nurse Gordon serves as a lead health educator at his current medical practice. He also serves as an adjunct clinical professor at several universities in New York City. Prior to being a nurse practitioner, Nurse Gordon has held roles at the manager and director level in areas of ambulatory care, medical surgery, emergency medicine, and case management. He earned his bachelor's degree of nursing from the University of Texas with honors, a bachelor's of arts in business management from City University of New York with honors. Nurse Gordon then went on to earn his Master of Science in Nursing from the Adelphi University in New York. Currently, Nurse Gordon is a doctoral candidate in the Advanced Clinical Nursing Practice and Public Health at the State University of New York, Buffalo campus. Nurse Gordon holds a national certification from the American Nurses Credential Center as an adult gerontology primary care nurse practitioner and as a board certification in ambulatory care and nurse executive. He is an active member of the American Urological Association. Please help me welcome Nurse Gordon.
All right, thank you, everyone. Thank you, Javon, for that introduction, and thank you guys for having me to discuss this most important topic about prostate health for men in the entire diaspora. I am going to share my screen. Just bear with me really quickly. So what I wanted to talk about today, just to piggyback off of what Mr. Finley discussed in terms of prostate cancer and why it's important for men when we reach the age to have the assessment done, is to talk about BPH or enlarged prostate. Also talking about sexual performance for men. At some point in our lives, male patients will have some sort of effect in terms of their sexual performance. And I wanted to talk about how to identify that, how to treat that, and how do we move forward. And then lastly, talking about testosterone, what is its role and why is it important for men's health? So I wanted to start off by just reviewing about the prostate, where it's located and what its function is. So the prostate sits just below the bladder and right in front of the rectum, and it goes through a tube called the urethra. This is where urine comes out of. And because of its location, if there's any dysfunction with the prostate, it can affect sexual functions and urinary functions as well. The main job of the prostate is just to secrete seminal fluid. So what is BPH, or what is enlarged prostate? So it is a non-cancerous enlargement of the prostate gland, and it's common in most men starting at really around age of 40. Similar in terms of urinary symptoms to prostate cancer, but the key item is that it's non-cancerous and it's just an enlargement of the prostate. To talk about the development of the prostate in terms of the lifespan of the male patient, starting at the age of 12, around puberty, the prostate doubles in size, and then around age 25, it continues to grow. For most men, they don't see any noticeable symptoms as it relates to the enlargement of their prostate until it gets to about around the age of 40. When the prostate is enlarged to a certain extent, that's when you start to have problems with urinary symptoms and or sexual function. I wanted to show briefly a diagram of what a normal prostate will look like and what a prostate that is enlarged would look like. So if you look on the left side of the screen, you will see that the prostate is symmetrical, meaning that it's equal in size. The brown tube here represents the urethra. This is what the male patient would urinate through. And you see that it's widely open. As we get older, again, starting at the age of 40, some men will start to feel some symptoms. And usually as they get to approaching 50, the symptoms will actually get a lot more worse. If you look at the diagram here on this side, you will see some white circles. This is representing the enlargement of the prostatic tissue. And as the tissues start to grow, it starts to squeeze on the opening through which the male patient would urinate through, the urethra. And in advanced stages, it actually can stop the urine. And at this point, some sort of intervention needs to occur. So BPH, or enlarged prostate, can take really the symptoms in terms of, is it obstructive, where it's really affecting the urethra, or is it affecting the bladder? If the typical obstructive symptoms for patients with enlarged prostate, where they are finding some symptoms, is that they may have issues starting to urinate, and this usually represents where they're pushing or they're straining, or they may have a varying level where their urinary stream is affected, where it's weak, or there's a start and stop of urine. And for some men, there may be some dribbling that occurs at the end. If the BPH is affected by bladder changes, a lot of the times patients may complain of urgency, meaning that they have this strong sensation to urinate, even if they don't necessarily have anything in their bladder. They may also have varying levels of frequent urination. There is a sensation that the bladder is not completely empty, what we call incomplete bladder emptying. And for some men, they may have varying levels where when they're sleeping at night, they get up to use the bathroom several times, what we call nocturia. I show a diagram here in the corner of the screen where it shows that for a man that has normal flow, meaning that they're not really affected by the symptoms of BPH, you see that the bladder has some urine in it. You see that the prostate, which is sitting right below the bladder, is completely symmetrical, so urine is able to flow. If there is an issue with the bladder, you see that the prostate is enlarged to a size where it's squeezing just below the opening of the bladder, and so there's some obstruction that occurs at that time. So BPH. or enlarged prostate, when is it necessary for the male patient to actually come into the doctor and medical provider to have that checked? It's important to note that while all men will have an enlargement of the prostate, the rate at which it enlarges and the symptoms in what they experience is not predictable. Every patient is individual and is different in that regard. When you come into your medical provider, we will do some objective measurements to see the varying levels of obstruction. Usually we will do something, I know in my office, we do urodynamic studies where we're just looking, we're using a computer to really measure the rate of which there is some sort of obstruction and how acute it is. With BPH, there's a progressive decrease in the size and the force of the urinary stream, what we call weak stream, and that the bladder feels like it's not emptying as it should when you were much younger. So who is at risk for BPH or an enlarged prostate? So I had said before that the symptoms usually start at the age of 40, but generally by the age of 50, the risk for BPH rises tremendously. Men of Black diaspora, and what I mean by that is men that were born in Africa and here in the United States where I'm located, or in the islands and the Caribbean, we have a high rate. We are at an increased rate for increased prostate enlargement and or prostate cancer. Men who have had their fathers who were affected by BPH, you're more than likely to have issues with your prostate. And as Mr. Finley had said in his presentation about prostate cancer, men who are overweight or obese, that also affect the prostatic tissue and your overall performance. Men who live a sedentary lifestyle, meaning that you're not trying to exercise, at least from a cardiovascular standpoint, at least 3 times a week, those men are also at risk for BPH. And some men who have erectile dysfunction can be a symptom of BPH, but it's also a condition separate from BPH as well. And that's why it's important to come into your medical provider to have the screenings done and to be evaluated to see which is which. So how do we diagnose BPH or an enlarged prostate? Usually in my practice, because I see a lot of urological patients, we would have something similar to this as an intake that we ask the patient to fill out. And it's really just asking about any changes in your urinary symptoms, and then we give them a score at the end. We're asking the patient, do they have any sensation where they feel that their bladder is not completely emptying? How often are they going to the bathroom on a day-to-day basis? Is there any sort of start and stop of the urinary stream? Do they have urgency? Is their urinary stream, is it weak or stronger than when it was? And if there's any straining or any nocturia going to the bathroom at nighttime. So according to the American Urological Association, based on that risk score, men who fall in the risk score from 0 to 7, we call that mildly symptomatic. That would just mean that we just treat them in terms of active surveillance, where we're just monitoring to see if there's any changes on a year-to-year basis with their symptoms. Men who score in the 18 to 19 range, moderately symptom, we're definitely doing some sort of intervention at that point. Maybe we're doing lifestyle changes and or some medications that we can give for that as well. Men who are severely symptomatic in the 20 to 35 range, we might do some invasive procedures, surgeries to try to shrink the prostate. So when you come into your medical provider, usually once a year, how we diagnose enlarged prostate, we first start off with a physical exam. And as Mr. Finley was saying, that generally right now that the DRE is not usually recommended as a screening tool, but I would say in our practice here where I am located, we still do the DRE, particularly because I have a large population of men who are from the Caribbean. And a lot of these men are affected by prostate cancer and enlarged prostate. So we do it. And there's a study that really just came out recently that says that 1 in 5 men with a normal PSA blood test, but if there's something on the prostate, meaning that it was never checked, they still go on to have prostate cancer. So it's super important, at least from our perspective where I'm located, that we still do the digital rectal exam along with the blood test to get a complete picture of the man's urinary health. We also do some urinary tests, the urine analysis, just to make sure that there's no issues related to infection that could be causing the urinary symptoms. And as I mentioned before, we do some dynamic studies, usually some diagnostic testing in the office, where we're looking at the flow of the patient's urine, called a uroflowmetry. And what that really is, we ask the patient just to pee into a machine, and the machine measures the rate and the flow of the urine. And then right after, we would just scan their bladder to see the amount of urine that's left in the bladder. If we also do some diagnostic imaging as well, because man's urinary symptoms, yes, there's enlarged prostate, but there could be other issues with the urinary system that affects the way how you would urinate, whether it's issues with the kidneys or the colon, for example. So we would do those tests. And we also do a cystoscopy if we think that any urinary symptoms is because of the bladder. We look in the bladder to make sure that there is no signs of inflammation or prostate cancer occurring. Now, the blood test, as was brought up by Mr. Finley, is one of the baseline screening tests. Whether you're screening the patient for prostate cancer or an enlarged or BPH or any other urological issues, the PSA is the baseline screening test. And here, where I am in the US, the numbers that we use in terms of the normal range, men under the age of 60, the PSA number should be between 0 and 2, meaning it should not be above 2. Men over the age of 60, it should be between 0 and 4. So the treatments for enlarged prostate or BPH, one of the first things that we would try based on the severity of the symptoms that the patient may or may not be complaining about is active surveillance. And so active surveillance would mean that we would do these screenings in terms of the type and the severity of the symptoms you're complaining about. We would suggest lifestyle changes, for example, diet, exercise, cutting back on some caffeine, things that you know that can irritate the urinary symptoms. And if that's not working, there's a whole host of medications that we can try along with active surveillance as the second step to try to manage symptoms or complications of an enlarged prostate. And then if medications is not working, we have a whole host of different surgical and procedures that we can try, leading from invasive all the way up to the most invasive. The point I'm trying to make is that BPH and enlarged prostate is something that is highly treatable based on the time when you come in to see your provider and the severity of your symptoms. I also want to talk about erectile dysfunction or sexual performance. And as I was stating, as we get older, for most men, sexual performance is probably not as sharp as when they were younger. So starting at the age of 40, BPH, but hormonal changes and other things that may be occurring in the body can also affect a man's ability to perform. For most men, erectile dysfunction is caused by physical problems, usually related to blood supply or blood supply to the penis. So any chronic condition that affects circulation in general will more than likely also can affect sexual performances if they're not managed. So for patients who have uncontrolled hypertension, diabetes, cholesterol issues, if they're not managed at some point, that male patient will have some issues with sexual performances. And I've seen that at both my internal medicine practice and at my urology practice. For some men who have neurological issues that can affect that as well. And also hormone levels, testosterone, which I will talk about next, If the testosterone level is low, that also affects sexual performance as well. So it's important that when you go into your provider, just be as straightforward as you can so that we can provide the best screening tools to really evaluate what's going on with you. Sedentary lifestyle, as I mentioned before, for men who are not as active as recommended, that also affects sexual erectile dysfunction. The guidelines is at a base, we should be doing at least 30 minutes of cardiovascular exercise at least 3 times a week. And now diets that are high in fat and carbohydrates and sugar, that also affects sexual performance. So how do we treat ED? How do we treat sexual performance issues? Again, the first thing we would do is to manage the underlying causes, whether it's related to some chronic illness like hypertension, diabetes, or cholesterol. Your medical provider will also go into checking certain lab work to make sure that they're in the normal range. And if they're not, to take the steps to actually rectify that. So for men, the main hormone in terms of sexual performance is testosterone. So we want to know if that's in the normal range, and if they're not, they may be a candidate for testosterone replacement. Glucose levels and cholesterols and thyroid levels are things that we would change. We also, like I stated on the previous slide, encourage men to really maintain a healthy diet and lifestyle. And then if those lifestyle changes are not working, there are several types of medications that can be given for erectile dysfunction based on the patient's preference and also their current medical condition. So my next topic, I wanted to talk about testosterone. So what is it and why is it important to the male patient? So testosterone is the main male hormone, and it's really responsible for all of the things that we associate being masculine or being a man with, not just sexual performance. Testosterone is responsible for muscle mass, for strength, for the growth of facial hair, metabolism, mental maturity as well. The testosterone levels will normally drop as we begin to age, but even as it drops, it still should be in the normal range, which I will bring up in the next slide. Low testosterone can affect sex drive, your mood, your ability to just develop muscles, or just your metabolism in general. So when we see patients in the office and we suspect low testosterone, we will draw the blood, but one of the things we look for is the range should be roughly about 250 to 1,000. Some labs will say 260 to about 950, but it should be in that range. And usually we would draw that levels if the patient is really complaining about some of the things that are listed here. So if they have a reduced sex drive, what we call a libido, if they are having issues where they're not able to maintain an erection, or if they get an erection, it doesn't last long, what we call ED. If they have an increased body fat, they notice that their muscle size is decreasing in strength, they're getting weaker. Their endurance is affected, and the fact that they may be tired or fatigued, even if they're getting a full night's sleep, the testosterone levels would be one of the things that we would check. And then lastly, if their mood is depressed or low, we would check that as well. So this is these are the things that I wanted to talk about. Thank you for giving me the time to briefly go over these topics. Devon?
Okay, thank you very much. All right, thank you very much, Nurse Gordon, for that very insightful presentation. All right, so just going to move right along to a testimony from Mr. Herbert Garrix. He is a prostate cancer survivor for the past 15 years. Mr. Herbert?
Are you hearing me? Hello?
Yes, we can.
Are you hearing me?
Yes, we can.
Hello?
Hi, we can hear you.
You hearing me?
Yes, sir.
All right, go ahead. Go ahead. Have I done something wrong with the phone? Oh my word. Hold on a minute. This look like I've done something that I'm not supposed to do.
Mr. Garrix, we can hear you loud and clear.
Okay, all right. So you said something and I didn't hear what you said.
No, so you can go ahead and present. You can go ahead and share.
All right. What is that you want me to share though? Tell you about my
All right.
experience?
Yes.
Okay, well, I'm one of those males who is not afraid of going to the doctor. And because I have a lot of doctor friends too, and we share issues of medical stuff. You know, I'm aware fully that, and of course, I'm a financial advisor. I work for Surgical for 32 years now. And I know that your doctors would say once you pass 40, 45, you should do a prostate test every year. So I would have really just every November do my complete physical, yeah? And I remember in 2008, when I did my medical, my doctor told me that my prostate was slightly enlarged. But he said to me, though, you're at the age where your prostate will naturally get enlarged. Some will become cancerous and some will naturally be treated and is okay. So I said to him, I want to know everything. So I wanted to be able to do all the tests that are possible. So he had me do the PSA. When I did it, really you view me, I was a little busy the year and to the end of the year because in insurance, that last part of the year is where we're going for $1 million round table and all of those things. So honestly, I didn't remember anything about the results and going for them. But I remember though in February, he called me and said, is it because you are aware that nothing serious is wrong with your prostate why you have not returned for the results? So I went for the results and he said, though to me at the time, that my prostate was slightly enlarged. And I said, what does that mean? And he said, it's natural at your age for your prostate to be slightly enlarged. But as I said, sometimes enlargement can go further beyond and beyond, or treatment can fix it. Anyway, I said to him, I want to know if there's anything else wrong or going to be wrong. So he sent me to do a biopsy. I got in touch with a biopsy through my a urologist through my daughter. Of course, they used to work together. My daughter was a nurse at UWI. So when I linked the doctor and told him what was my reason for wanting to do the biopsy, he said, okay, that's all right. So he did the biopsy, and 2 weeks time, the result was out. When I went, the doctor put up his two hands and showed me his 10 fingers, and he said I did 6 clippings from your prostate. 5 areas are crystal clean and clear, but one is showing me something that I'm not even certain what it is. So I said to him, is it cancerous? And he said, no, man, I can't go there so yet. But it is showing like a sign that I really not so certain about. And I said to him, you know what? I want to be certain. And I'm not taking no chances. So I said to him, what can I do to remove that little doubt? And he said, you have options of, and he said, try herbal stuff, or you could do radiation, or you could remove your prostate. So I said to him, so can I live without my prostate? And he said, yes, man. What for people are living without a prostate? So I said to him, just tell me if I or if I do the thing. If you do radiation and it doesn't work, you might not be able to do surgery. And I said, oh, I see. So I said, naturally then, surgery is the right thing to do. Once I can live without my prostate. So because we were talking in that kind of, just novel way, I said to him, Doc, if you're in my position and you're as old as I am, tell me, what would you do? And he said to me, without a doubt, I would have removed the prostate, that I can live without it. And I remember hearing men talking about prostate and impotence and all of that. So I started laughing. And he asked me why I was laughing like that. And I told him. And he started to laugh too. I said, boy, you just sound like a different kind of man. You're not the normal man. Because the normal man would be so fearful. I don't want to remove the prostate because they're fearful. They're so fearful of impotence. And I said to him, you know what? I'm 55 years old now. I think I've lived a good life. I get 4 nice children and they're doing okay for themselves. And I would prefer at this time of my life for me to be still alive and serving some men and are serving people than for some men to walk in a casket with my body in there. And believe you me, the doctor laughed and him laughed and him laughed. And he said to me, I want you to be an ambassador for men folk who are died from prostate cancer. And I said, no problem, man. So I called my daughter. She was the first person I called when I told her, and naturally because of her medical experiences. And then I called my wife and I told her too. And then we agreed and I decided to remove the prostate. So I called up my doctor and told him that the first possible date that he could find, I am ready. So this was in March. And then, so June 26th, I removed my prostate. Since that time, it's still is. Hello? Hello?
Yes, we can hear you.
Yes, so June 26th was the date.
Mr. Garrix?
Hello?
Yes, Mr. Garrix, we're just hearing you now.
All right, so June 26th, he made the arrangement and I did the surgery at UWI, 23. I did the surgery, it was successful. I'm alive and I'm still well, not impotent. And I do my PSA now. At the time, he said I was to do it, I think, every 6 months. And after that, he graduated me to every year. And then afterwards, I'm now doing like probably every other year. I did it, the last one I did was in December of last year. And I'm still at 0-0. So I have no recurrence of anything coming back where my prostate is concerned and all of that. I would have been able to convince, I think, about 3 or 4 of my friends who had issues. One of them, I think, no, 2 of them were actually kind of cancerous because the doctors told them that they had gotten to cancerous stage. They were so afraid to remove the prostate. And when I sat them down and I told them exactly how my experiences went and all of that, I was able to convince them. And the 4 of them had their prostate removed. And they are doing good and they're happy. So basically, that's it. Hello?
Yes, I hear it. All right. So thank you very much, Mr. Garrett. I truly agree with that you should be an ambassador for prostate PA. And so you have planted
The truly told,
three of your friends.
yes.
So I
No,
just
four of
want to
them,
thank
four of them.
four of them, right?
Four of them, and two actually was told that the prostate is cancerous. I
Right,
was not told that mine was cancerous, but the doctor said there was something that he doesn't know what it is and it could become cancerous.
right, right,
But two of them actually was told that yes, you have cancer. They have
right,
removed it, and this is probably about some 6-7 years, and they're fine. I've not heard them say anything about the cancer coming back or anything like that.
right. So I just want to thank you for that testimony.
Yeah, man, that's all right.
Awesome. All right, thank you very much.
You're welcome.
All right.
All
All
right.
right, ladies and gentlemen, thank you, sir.
You're welcome. You're welcome. All right, ready again. Try
All
to
right,
go.
so ladies and gentlemen, so are there any questions for any of our presenters? We heard from Nurse Finley, we heard from Nurse Gordon, and they both share a wealth of knowledge on prostate cancer, also on benign. Erectile dysfunction, and also the testosterone. All right. So you have heard a wealth of knowledge. Are there any questions, any concerns, any comments? Floor is now open.
Good evening, Javon. Good evening, everyone.
Evening.
Thank you for a most enlightening session. I am a little disappointed we don't have more people because we do want more men to join us and more persons to hear what they need to do to support our men in being more health seeking. I had a quick question. I'm not sure for which of our presenters if they will be able to help me. I had a friend several years ago who had prostatitis, and I was just asking about the difference between that and BPH.
So I'll take that. I think so. Prostatitis is actually very common for a lot of older men. So what prostatitis means is that it's just an inflammation of the prostate, and usually it's likely occurs if there was some sort of urinary tract infection that was not treated previously, and then it traveled to the prostate. That's one of the most common way it occurs. The difference between BPH and prostatitis, like I said, prostatitis is just an inflammation of the prostate. So the prostate may temporarily be inflamed or swollen, whereas with BPH or enlarged prostate, the actual tissue of the prostate that has grown as the man got older.
Okay. Is that cigar slide?
She said thanks.
Okay. All right.
There's a
So we have
question in the chat.
we have a question in the chat. So hold on. What is the medication used to treat BPH?
Nurse Friendly, you could open your mic.
Hi, good afternoon. So typically here in the Bahamas, we would use either Averdat or Flomax, or sometimes you would see a combination of both being used to treat BPH.
Thank you. Earlier, some persons say that they can't unmute.
Just raise your hand and I'll unmute you, but I won't be unmuting everyone at once because some persons don't know how to control their mics. So once you raise your hand and put it in the chat, I will unmute you.
Okay. So I think Black Adona and Child have a question.
Your mic is unmuted. You can go ahead. Black Madonna, I unmuted your mic. I'm going to do it again. You can go ahead with your question.
Oh, greetings, everyone. Stephen from the Bahamas.
Go ahead.
My question is, having prostate cancer and having the medication. Sometimes I have, I don't know what you call flare-ups, where I would have pain in different joints. I was wondering if that was regular or I would need to increase the dosage of the medication. I mean, what do you guys think? And the next question is there any natural supplements I could use to assist the medication? I am presently on Orgovix, and I can't remember the name of the next one right now. So I'll listen to your answer. Thank you.
Hi, so thank you for your question. That's a pretty good question. So as it relates to the painful joints, one of the things I would recommend is that you keep in contact with your physician, whether it's your urologist or the oncologist that is providing you with routine follow-ups so that you can have these discussions regarding pain management and as well as the natural remedies, because we don't want you to take something that can possibly cause an adverse reaction with a medication that you're already on and cause something bad to happen. So I would just suggest that you stay in contact with your physician that's managing your care right now, and so that you can get guidance on the pain medication as well as natural remedies that you would be interested in.
All right, thank you. All right, so we have Mr. Sands.
Nurse Friendly and Gordon, you can keep your mics open. Mr. Sanch, you can go ahead. Mr. Sanch, your mic is unmuted. You can go ahead.
Seems like we lost him earlier. So are there any more questions? All right, so I see where iPhone 2 is asking, is antibiotic an option for treatment?
Yes, I think that question is related to the prostate status. I think that's what that question is related to. And if it is, then antibiotics is a treatment option for that.
I agree.
Okay, the person has responded. Okay, great. All right, so are there any more questions?
Mr. Sands, I unmuted you again. But we're unable to hear you if you're speaking. If you have a question, you can put it in the chat.
There's a reason, Alia.
I already gave him permission to unmute his mic.
Okay.
He's not,
Oh, yes.
go ahead.
Oh, sorry. Greetings again. What is the percentage cases of men after going through BPH and the prostate cancer process of returning back to normalcy? Being a young man, this is really, a really challenge for me. So I would just want to know what is the percentage or what would be the procedure. Now that my numbers are kind of down, um, what is the percentage? Can anybody answer that you have recorded?
Sure, I'll take that. Thank you for the question. And I see in my office, and based on Mr. Nurse Finley's presentation, most men, and I would say above 99% of men who's been treated for prostate cancer and or related to BPH, within the first 6 months to 1 year, they actually go back to having their full performance. But what's important is that you're following up with your medical provider at the appointed appointments that have been scheduled for you to make sure that you're responding to treatment and things like that.
Thank you very much. Thank you.
You're welcome.
I can't see all the participants, but we have doctors on here that live in the Bahamas. Yes.
Finley, Dr. Morgan is on.
No, Dr. Morgan signed off already.
Yes, there were doctors on.
Dr. Finley.
All right. So I think there's a question in the chat. All right. So this one is from Mr. Sands. Does BPH or prostatitis put a patient in a more favorable group to develop prostate cancer? And can these conditions be reversed completely?
So research is showing that BPH or nor prostatitis increases a man's risk for developing prostate cancer. Unfortunately, the misinformation related to prostate health says that if you have BPH, it increases your risk for prostate cancer. If you have prostatitis, that increases your risk for prostate cancer. However, the research says that that is not true.
Okay, thank you. All right, so are there any more questions? All right, so seems as if there are no more questions. So the Nurse Finley, Nurse Gordon, really want to express our appreciation for coming out and sharing with us on a topic that is in some senses a bit scary for men in general in the Caribbean. And I guess based on just the procedure in itself for screening, the DRE are what are some of, is one of the setback for Caribbean men in going for screening, because everyone is afraid of the whole DRE. So they always, most of the times, they catch the prostate cancer in a more advanced state. And thanks for sharing with us on how persons can prevent. Thanks for giving us what some of the risk factors. I realized one of my friends shoot a message for me and say, hey, no more drinking of milk. And I was like, so I was like, okay. So persons actually truly, really and truly appreciate the information shared today. And also persons who want to share this information and want to recap, you can go on our YouTube page. The video will be there. It's on Omega Kappa, chapter of Sigma. All right. I know ask our president just to say a final, Madam Alia Brown, just to give a final. See.
Thank you, Javon. I just want to say thank you all who have presented, Nurse Finley, Nurse Gordon. Thank you so much for your knowledge and experience in this area of man health. It's very important. It's something that we don't talk about as much. It's a topic that, men kind of shy away from, especially when it comes to their health, because, they really, really don't like to go to see the doctor until they're actually sick, like really, really sick. So we this week is Men's Health Week, which is from June 10th to June 16th. So we thought it was fitting to do something, a talk or a session with men in the Caribbean about their prostate health, which is a challenge within not only the Caribbean, but internationally as well. So we just wanted to bring awareness to prostate health and what's going on and what our statistics are looking like and what men can do to prevent, to decrease, to slow down the progression to prostate cancer and even BPH. So I just want to say thank you all for joining us this evening. We are the Omega Kappa chapter of Sigma Theta Tau International. We are the only Caribbean chapter, even though there's more than, I think, 600 plus chapters worldwide, filled with nurse leaders trying to change and impact healthcare around the world. So that is what we're doing. We do that multiple ways, whether we share information, whether it's with our members, whether it's with our nursing professionals, or it's within the community. And this is one of our community efforts now, trying to inform and bring awareness to topics that are impacting our communities. So we thank you once again for joining us. And if you would like to review this segment, it is on our YouTube page. We are streaming live. So you can always go back, click on the link, even subscribe to our channel, and you can be able to watch this session again. I'm over and out. Javon, thank you so much.
All right. So one more thing, I would also like to thank our Mr. Hubert Garitz for sharing his testimony with us. Trust me, really brave, and he's really an ambassador for persons to go and get treated, go and get tested, or whatever it be, screening and all of that. And if you listen to how calm he was in presenting and sharing his testimony, you can just imagine how calm he was, just the same when he was going to the doctor, checking up and all of that. So I really want to thank Mr. Garrix for sharing with us and taking the time to share with us today. All right.
Thank you, Mr. Garrix. I don't know how I just missed you in my thanks, vote of thanks, but thank you so much for your story. And you sound like you're ready to go another 50 years. Thank you so much. With that said, I wish you a pleasant good evening and be safe.